Welcome. Good morning, good afternoon, um, good evening, I suppose, or early morning for one of our presenters who's kind enough to join us from Australia at 1 a.m. Thank you so much, as always, for taking the time out of your day to join us as we continue our 2022-2023 grant presentations. These are always really wonderful to see how our projects played out throughout the year and to see the final outcome. So we thank our presenters for being here and for you for joining us in your busy day. Next slide, please. The Global Rural Nursing Virtual Collaboration Learning Grant, if you are unfamiliar with that, is generously funded by the MHCH Foundation. We always like to thank them as they are the sole funders of these grants, and they're entirely responsible for allowing us to make these collaborations happen. The Global Rural Nursing Virtual Collaboration Learning Grant provides funding to programs that promote collaboration, learning, and global connections. The opportunity is designed to foster partnerships between international nursing students and educators who collaborate on rural community health projects. If you have not participated in a grant in the past, we always encourage you to be a part of the program. We are hosting a pre-application webinar on February 21st, both at 9 a.m. and 3 p.m., and that is Central Time. That session is going to review best practices for building a compelling application, the intention and goals of the grant, how to apply, how funding is distributed, and how to engage your students. We are also going to be providing support for anyone who is interested but does not have an international partner. Of course, you can always email us if you are interested and seeking a partner and don't have one, or we can work together on that during that session. And lastly, we do have one additional webinar following the one you will see today as part of this series. That's going to be on February 1st at 7 a.m. Central, where colleagues from the University of South Dakota in the United States and the Kabosho Institute of Health and Sciences will be, in Tanzania, will be presenting their session, which is the promotion of global health competencies awareness through assessment of vulnerable populations. Next slide, please. Just a brief housekeeping note that while we are happy to receive any questions that you want to share throughout the presentation via the chat feature or the Q&A feature, we will be holding questions till the end. Feel free to go ahead and drop them in, though. We don't want you to forget anything, but just know we're not avoiding them. We want to allow the flow of the presentation to continue. Thank you. And today I would be privileged to introduce to you our presenters. Abby Grammer Horton is an assistant professor at the University of Alabama's Capstone College of Nursing and is a four-time graduate of the University of Alabama. She earned a Bachelor of Science in Political Science in 2006, a Bachelor of Science in Nursing in 2010, a Master's of Science in Nursing in Rural Case Management in 2011. She completed her doctoral in instructional leadership with an emphasis in nurse education in August 2021. Dr. Horton currently teaches in the undergraduate nursing program at CCN with more than 10 years of higher education experience. Her interests in nursing practice and research include health policy reform, diversity, equity, and inclusion, and issues concerning health and wellness, mental health, holistic care, access to care, spirituality, and complementary and alternative medicine practices. Dr. Horton also teaches part-time for the University Honors Program and serves as a Bama Wellness Class Educator on UA's campus as a certified health and life coach. Additionally, Dr. Horton is active in Alabama State Nursing Association at both the state and district level. She is a 2013 recipient of the ASNA New Member Excellence Award and the 2018 CNN Ernstine Tucker Opening Doors Inclusion and Engagement Award. Dr. Horton is also a Blackburn Institute Fellow and remains active on UA's campus in the wider West Alabama community. Febi Tambala Jamison is a lecturer in community health nursing at Kamuzu University Health Sciences School of Nursing and the Community Health Studies Department. In 2009, she received a minor in global nursing from the Amsterdam University of Applied Sciences, followed by her Bachelor of Science in Nursing from the University of Malawi, Kamuzu College in Nursing in the same year. She earned a pediatric assessment skills from the Royal College of Nursing in Birmingham in 2011, a postgraduate university certificate in midwifery from the University of Maui, Kamuzu College of Nursing in 2013, and a master's in public health and epidemiology and biostatistics in the University of Melbourne in 2018. Prior to her current position, Febi served as a nursing officer in the Ministry of Health, Queen Elizabeth Central Hospital on the Pediatric High Dependency Unit, where she later became the Senior Nursing Officer in Pediatric Accident and Emergency Department, followed by the Principal Nursing Officer in the Neurosurgical Department. Throughout her career, Febi has received many awards and accolades, most recently being named Best Queen Elizabeth Central Hospital Nurse Leader in 2019 from the National Organization of Nurses and Midwives of Malawi. She serves as a KCNBT Campus Welfare Chairperson, is dedicated to the welfare of health workers in COVID-19 centers in Malawi, and mentors and assists youths in finding international scholarships. So I would love to turn this over to our presenters as they share with you their presentation today. Thank you. Welcome.
Hi, everyone. It's wonderful to be with you all today, and we're happy to share our collaboration that's been ongoing for more than 2 years. This is our second project funded through the Global Rural Nursing Exchange Network, and it's been a privilege to work with our friends and colleagues now in Malawi. Our project for this year is called Examining the Impact of the Malawi, Alabama Global Nursing Education Rural Health Literacy Project. And this built upon the work that we did 2 years ago when we looked at vaccine hesitancy. And so, as we looked at vaccine hesitancy in our rural communities, looking at our next door neighbors, we saw that not only was vaccine hesitancy an issue, but really health literacy played a role. And so, we partnered together then to submit another grant, which we were thankful was funded. And we carried that out this past year for the 2023-2024 academic year. So I included this picture, which we actually used in our first grant funding. These two images are taken, one from Alabama and one from Malawi. And one of our students from the original funded project put this together and asked us to be able to identify which was Alabama and which was Malawi. And what we were doing in that exercise that first year together was to see how beautiful both locations, really were, but also to point out how similar they are and how difficult it is when you look at a rural community to be able to identify, is it here close to home, or is it, our friends and colleagues across the globe? And so it really does help us remember that we're more alike than different. And that's been the theme of the last 2 years, is how are we similar? Yes, how are we different and unique? And we can celebrate that, but we also want to really celebrate how we're the same and how we're similar and how we have those connections together. And so that really just harkens to this cultural humility that we have tried to cultivate on our team. And I think we've done a really good job of that. So we're going to go through and acknowledge our faculty and student collaborators because, again, Fabi and I have worked closely together, but we could have not done this project without our entire team of faculty and students. And so there are many, many people who have made this project work, and we've tried to acknowledge as many of them as we can on the presentation. We'll do an introduction of the project and just the rationale behind why we felt like this was an important project to take on, do a brief introductions of the schools and talk about our objectives and goals, our overview of the project, talk a little bit about the grant funding process, review our outcomes and some of the lessons learned, because we hope that you'll be inspired either to do a similar project, to apply for your own GRNEN grant, or to be able to form your own collaborations perhaps. So we hope this is helpful to you. So for the UA side, we'd like to thank the University of Alabama Capstone College of Nursing. The administrators were amazing in helping us in this grant application process, but also the faculty, staff, and students who supported this work. So I would like to introduce my dear friend and colleague, Dr. Paige Johnson, who we absolutely could not have done this project without her. So
Good morning, everyone. I'm Paige Johnson, and I serve as the Saxon Chair for Rural Health at our college. And this project has been such a wonderful utilization of resources, and it has really just deepened our understanding of healthcare. Truly is, it spans the globe, and we can learn from each other about ways to improve health literacy and health outcomes. So we're just very thankful that we had this opportunity to create this team and conduct this intervention in our communities. So thank you all for being here, and thank you all for listening, and thank you, Abby.
thank you, Paige. And then, of course, we'd like to individually recognize our 11 students who participated on the UA side. So we have Sarah, Amoy, Katie, Mackenzie, Maddie, Alex, Claudia, Kennedy, Rebecca, Sam, and Haley. And they were all wonderful fifth semester students who were participating in this project through Community Health, the nursing course that they took in their fifth semester. So super excited to have had them participate, and you'll see some of their contributions throughout the presentation. And now, Fady, would you like to introduce your collaborators?
Yeah, thank you, Abby. It was an honor to work through the project with you from UA. So in Malawi, we had Associate Professor Belinda Gombachika, who is also here. Prof. Gombachika.
Hello, good morning, everyone, and good afternoon, those of you in Malawi. It was a pleasure working with you colleagues. We have learned quite a lot, especially working with the rural community and also working with our students on a one-to-one. We appreciated their skills and also the skills our colleagues from Alabama had. Thank you so much. Thank you.
Okay, thank you so much, Associate Professor. And we also had Mrs. Katola, Mr. Sagawa, and Ms. Zimbiri, who also made this work possible. And I would like to thank them as well. The next slide. So the students, we had 9 of them. We had George, Zao, Tamandani, Charity, Maggie, Doreen, Deborah, Prudence, and Janjani, who made beautiful contributions to the project as well. Thank you.
Thank you. So this was really a collaborative effort, as you can see, and we endeavored to create a collaborative community of faculty and students from both of our institutions with great institutional support. So both of our groups explored strengths and challenges facing rural communities in relation to health literacy and health education barriers, and we would like to explore that more with you. So why this project? We really wanted to look at ways to overcome health literacy challenges and barriers through collaborating with our nursing school students and our faculty to implement a project in a rural community that was neighboring to our near campuses. We wanted to make sure that we were addressing the issues and the challenges that were most relevant and were most likely to be seen or encountered by our students. And so both Malawi and Alabama share a lot of similarities, as I mentioned. We're largely rural areas, and health literacy rates are really difficult to track. So in looking at the literature, there's a true dearth in the literature when it comes to new literacy rates, and especially health literacy rates. And so we knew when we were going out into our communities with the vaccine hesitancy project that we noticed there were a lot of misinformation, a lot of myths, a lot of challenges with people being able to find reliable information and to understand the information that they were actually accessing. And so that was the inspiration behind this second kind of reiteration of the project. So we both looked at this rural health literacy challenge, and we're both public universities that offer medical, nursing, and biomedical health sciences programs. We've named several of the types of programs that we have, and we just want to give you more information so that you have it available to compare the very similarity components there. But the University of Alabama is home to the Capstone College of Nursing, and we're recognized as a national innovator in clinical simulation, but we're also very well known for our rural health focus, particularly in our undergraduate and graduate programs at the master's level. And so we do offer the BSN, the RSN to BSN master's programs and doctoral programs, including a joint PhD, an EDD, and a DNP. And so we just wanted you to have those pieces of information about our different college homes. And now we'll share our objectives and our goals. So we wanted to be able to share among our groups, both Malawi and Alabama, the strengths and challenges that we were seeing and facing in our respective communities that we identified. For us here in Alabama, we identified Hell County, which is about a 45-minute drive from the University of Alabama's downtown campus. And so we wanted to serve that population. So we did a community-based needs assessment. I really asked the community what it was that they needed in terms of resources and education. And we wanted to be able to identify evidence-based practice strategies that would help us be able to provide that community with the knowledge they needed to overcome those health literacy barriers. One of the challenges that we had is when we did a literature review, even looking at, internationally, looking at the literature, it was difficult for us to find current up-to-date health literacy information and studies, statistics for our individual countries, and then all the way down to the counties. And so that was a challenge. A lot of the information was more than 15 or 20 years old. And so we wanted to develop culturally appropriate interventions to implement in our respective communities and be able to co-present this work to each other internally and then amongst our group as a whole so that we could learn kind of that from, with, and about. So we actually built this collaborative community, like I mentioned, based on our original established relationship from 2021. And we identified the health literacy barriers for each of our communities. And we decided that we would want to strengthen our institutional partnership with this capacity to actually look at health literacy and how we can do collaborative nursing education with a global perspective. And so not only for our students to be able to see the challenges that are in a neighboring county while they're here at the University of Alabama, but also to see that many of our friends and colleagues around the world are also facing very similar challenges, although on the surface we may look very different. And so again, we explored these strengths and we had a lot of support from GRNEN and of course the MHCH Foundation funding was instrumental in being able to help us implement our project. So when we had our meetings, we met once a month and we met via Zoom. We had a lot of challenges, which we'll talk about, but we were able to overcome those because we wanted to be able to learn about these different topics and present them together and have students really interact with the faculty and the other collaborators on the project. So we talked about health literacy and cultural humility, healthy behaviors, health education. We talked about program planning, implementation, and evaluation, so what our project would actually look like at the end of our time together. And then we even discussed motivational interviewing because we wanted our students to understand that for our project to be successful, we needed to have buy-in from the community and we needed to be able to meet their needs, not be able, not just be in their community telling them what they needed, but we wanted to meet the needs that they had. And so part of that is having a conversation, and we really emphasize to the students on both sides that a reciprocal relationship is so important, and that the partners that we have in the community feel as if we are learning and helping them as much as they are learning and helping with us. And so that we're giving back to them and that we're not just being very prescriptive in what we do in the communities, but that we're listening to them and we're taking that feedback and implementing it into the work that we do. Communities also like to know that we're going to have a lasting relationship, that we're not just going to come in for a day and then not have any other contact with them. And so that is really foundational to building relationships and rapport with the communities that we partner with. And so we made sure to emphasize that to the students. So everyone on the team helped with the planning and implementation and helped us achieve the project objectives, which we're really pleased to share with the rest of you today. So Our project implementation, when we looked at the health literacy rates, we saw that about 36% of adult Americans only have a basic or below basic health literacy skills. Overall, looking at different statistics, you'll see different numbers, but in the US, typically you're going to see that Americans have around a 6th to 8th grade literacy level. So 6th to 8th grade levels with us would be like a middle school, junior high school level education of reading. So kind of that mid tier education. We're in a K through 12 system, meaning kindergarten through 12th grade. I know that doesn't translate globally, but that's looking at, you know, a preteen or early teenager basic reading level. And then to see that 36% of overall adult Americans only have a basic or below basic health literacy skills and have that literacy level, that makes a lot of sense because health literacy usually is going to be lower than the overall literacy rate for your community. And so that just means that it's difficult perhaps for us to be able to do informed consent or for our community members or patients to be able to understand prescription medication labels or education teaching sheets or things like that. And so it's really important that any education that we do with our patients or our clients, that we have a good conversation and that they're able to do read back verification, that they're able to tell us what it is that they learned. So only about 12% of Americans overall are considered proficient in their health literacy skills. And it was really difficult to determine that at a state and county level. And so there weren't a lot of good numbers, and we saw this across, across the world too. With Malawi, they had a difficult time being able to pinpoint those for the specific populations that they were working with. We also know that because of social determinants of health and health disparities, that certain demographic groups are at a greater risk of having low health literacy rates and poor outcomes because of that. So people who are considered elderly or the geriatric population, underserved minority groups, immigrants, and those living in rural areas, and so many other vulnerable groups are considered at a greater risk, perhaps because of access to resources, perhaps because of discriminatory practices or any of a number of considerations. And so another challenge then is that the health literacy is understudied overall, but is also very much understudied in those rural and underserved areas. So relevant data is scant. We do want to mention the Healthy People 2030 objectives that we will see, mentioned at the U.S. level, but also that is mentioned with the World Health Organization and even United Nations. One of the goals is health literacy as a central focus of Healthy People 2030, with the overarching goal of being to demonstrate this focus of eliminating health disparities, achieving health equity, and attaining health literacy to improve the health and well-being of all. And so we've linked the article and the web page here for you if you'd like to explore that more. So with those in mind, we created learning objectives. We wanted our students to be able to achieve a greater understanding of why rural citizens in Alabama have lower rates of health literacy. We wanted to be able to provide reliable resources to educate our clients in this population-based needs via this community needs assessment that we conducted. And we wanted students to be able to feel comfortable creating this information based on reliable resources and then disseminating and teaching their clients from this information. So we educated clients on the benefits of regular healthcare access and how to access trusted and reliable health education information. And we told them about resources in their community that they may not have been aware of. So we plan to use original health literacy brochures to educate Hill County residents on the importance of just basic wellness principles. We also looked at the data, and for Alabama as a whole, obesity, overweight, cardiovascular disease, diabetes, and cancer are going to be the top concerns in terms of health and wellness. And so we did education on those topics for these clients. And so while visiting the Dollar General Market, we offered help teaching on these topics, blood pressure checks and healthy snacks. We had free swag, and we had different stations set up where folks could look at what cholesterol looks like when it's high and how that narrows the artery. And we were able to have really interactive conversations with those that stopped at our tent that we set out in a parking lot in Hell County's new Dollar General Market, which was a great addition to the community because it added another source of fresh fruits and vegetables that they had been lacking because they were really in a food desert situation. A lot of times you'll see that we have a food swamp, meaning that there's a lot of fast food options and not a lot of fresh food options. And in this particular case, it was more of a food desert where they were having to drive more than 20 minutes to be able to reach a location that had fresh fruits and vegetables. And we even had pictures of the inside of the Dollar General Market, and many of the shelves where the fruits and vegetables were supposed to be housed were actually empty because it was the only source in the community for many, many miles. So while planning, we did make a lot of modifications to the times and dates that we we're looking at for this implementation day because the Dollar General Market were really concerned about disruptions during high traffic times and parking constraints and other concerns because, again, this is one of the only places in this community where they have access to this fresh food. So we worked with them and they were very gracious to allow us to come for a 4-hour day in the middle of their rush hour. So we spent 4 hours at the Dollar General Market in Hell County, and we provided the health literacy information in the form of brochures and pamphlets that these students pictured here actually created. And we bought the healthy snacks from the funding through GRDN at the Dollar General Market. So rather than buying them in Tuscaloosa in our grocery stores, we actually took that money and took time to go through, shop in the Dollar General Market, and then we took bags and bagged up individual snacks for families to take and then put a lot of teaching materials in them so that we could just hand them the bag. And if they had time for us to have a discussion, a conversation, a blood pressure check, then we were able to do that. And so we felt good about being able to put money back in the community that was having us come. And I highly recommend that when you're doing your own implementation projects. So some of the strengths is that we did provide that free health promotion and snacks. Meaningful conversations took place, even from some of the employees that took their breaks. We visited a vulnerable rural community to really learn and invest in its community members. And while this was a 1-day, 4-hour excursion to our next door neighbor, we will definitely be continuing our relationships, and we have continued to do things in Hell County to partner with them. So I think that that's an important part of the strengths of this project. Some challenges, we had some inclement weather. It was end of May for us. That means that it's starting to become late spring, early summer. So it was very cloudy and a rainy day. So a little bit unexpected for that time of the year for us. So inclement weather definitely played a role. They weren't quite as busy as we would have expected at lunchtime. And then there was definitely some community hesitancy to engage with what we would consider outsiders. We did have people who are really known to the community in terms of having Dr. Johnson there, who is very well known in the Hell County community, and then our associate Dean of Nursing for the undergraduate program, Dr. Michelle Cheshire, who's really been a champion of this work, who has a residence in Hell County. She was there and she was instrumental in helping us be able to engage. But it's really developing those relationships that's key so that we aren't seen as outsiders. This is one of the brochures. We had 3 overall. This is one of my favorites because it really speaks to the health literacy component. And so this was created by one of our student groups. We split the 11 students into 3 groups, and they were asked to create a brochure on a topic that was relevant for Hell County residents. And so this is an example of using a SMART acronym to talk about health. And that was a really well-received brochure. Completely student-led. So our objectives, how did we meet these objectives? We successfully developed the educational brochures, which is that primary prevention piece on key health disparities. We researched the health status of the Hell County population and identified those health risk factors. We had conversations with the community to see what their needs were, so that if it was something different than what the data was showing us, we would know to address those challenges. And then during our implementation, we were able to teach on cardiovascular health, obesity, hypertension, and we did mention diabetes and cancer as well. And then our relationship with our community partner, we were able to establish a working relationship with a Dollar General market manager, and we have a sustainability plan that's really been fortified by having this relationship between the Dollar General market manager and CCN. So now we're happy to turn it over to our colleagues. Thank you, Fabi.
Thank you, Abby. Thank you, everyone. So this is the Malawi part that I'm going to present to you. The next slide, Abby. All right, so in Malawi context, generally, we all know that health literacy means the ability of a person to obtain, understand, and make use of the health information in order to maintain and enhance good health. So if you are better informed, you're able to make good choices and good habits in order for you to prevent conditions like chronic conditions. So most Malawians, especially adults, have limited health literacy. Hence, they have difficulty to manage this type of conditions and other conditions. So in turn, you'd see that in most of our hospitals, we have higher hospitalization rates. And we also have higher avoidable mortality rates. We do have more healthcare expenditure because of low health literacy. And being a low resource country is really having an impact on our health system. Next slide. So Malawi is a small country with about 17 million people, but it also ranks as one of the world's poorest nations. Well, despite that, we have high rates of infectious diseases, but we're also impacted with non-communicable diseases. So of the total deaths that occur in Malawi, 28% are from NCDs, and cardiovascular diseases covers 12%. And diabetes, those with connected to obesity, we have also higher rates of about 21% among females and 16.1% among males. So if you have a good health literacy level, it has an impact to improve this kind of chronic conditions. Next slide. So we developed also our objectives in collaboration with our colleagues at the University of Alabama. So basically, we wanted to enhance the skills, assessment and intervention skills among our students on health literacy in our communities. So basically, we also wanted to assess what were the barriers of having a proper health literacy in one of the rural areas in Blantyre, so which is about also an hour or two drive from our campus. And also we wanted to specifically look at what's their level when they say they are sick, where do they go to? In terms of chronic conditions, in terms of sexual reproductive health, especially among the adults. And also we wanted to intervene based on the problems that we will find during our health assessment. On planning, so we planned the next one. Yes, so we planned with the village headman and also members of the health committee in the village that we chose. So with the students, they developed questionnaires and they took from the WHO questionnaires related to health literacy. So they developed the questionnaires on chronic conditions to assess the adults population. So they were also in groups. So we had 9 students. They were divided in 3. The three looked into the adult population. Another 3, they looked into the adolescent population, and they were assessing issues regarding sexual and reproductive health. And the last group was also looking into the under 5 children to assess malnutrition. So on the second day after they have asked, after they asked the questions, we were busy doing the data analysis to see which areas were crucial for us to intervene. But not only this, we also conducted BP checks, diabetic measurements, as well as nutrition assessment on the children. So on the third day, not consecutive days, but we went there once weekly. We had the intervention day where health education was conducted and other services. Next slide. So during the community assessment, the findings, we had 55 adults comprising of 43 women and 12 men. So we screened, as I mentioned before, blood pressure, and about 25% of the population we screened, they had raised blood pressure, of which they just staying without knowing that they had raised blood pressure. So 36 participants. So with blood glucose, we scanned people who had risk factors. So about 36 people were checked their blood glucose level. That's the random one. And 19% of whom we checked, they had raised blood sugar. And then out of these, one of them we had to refer because it was really very high, about 356 milligrams per deciliter. So the group that were doing assessments of the adolescents, they had about 70 adolescents. So they assessed their sexual reproductive health, which consisted of psychosocial issues, youth-friendly health services, family planning, which is very vital, as well as issues concerning sexually transmitted infections. We also did nutrition screening to all children that were there below 5 years. The next. All right, so from our findings, as I've mentioned, we found people with high raised blood sugars, raised blood pressures. So we conducted health education. So on the conditions, especially diabetes, hypertension, as well as cervical cancer on the adult group. And we also taught them to have regular checkups at least twice a year as per recommendation by WHO. We also educated them on diet modification to make good choices, as well as to follow the plate method, which looks into portions as well as healthy meals, and also physical activity and exercises to tackle the sedentary lifestyle, which is also an exposure to the chronic conditions. So in our rural communities, we have a problem of alcohol intake, even among adults as well as the adolescents. So it was also an issue that we intervened, and also smoking plus reduction of salt. Next. So with the adolescents, we talked of abstinence, health education on consequences of risk, teenage pregnancies, and also if they have STIs, where to go and how to prevent them in the future. We talked of also another issue, which is also raising eyebrows here in Malawi, about sexual harassment. People have issues of not reporting things like this when an incident happens. So we formed a community group which will also be looking into issues, and also to take people appropriately where they can go when they face issues of sexual harassment. Next slide. So we had strengths and challenges. The community that we worked with was very receptive, and they came in large numbers, as I've mentioned. We had positive response from them after sensitization, which clearly indicated that we can reach out to a number of people through these awareness sessions and outreach sessions in order to increase the health literacy of our communities. We also had full support from Kuhe's administration. As I've mentioned, Professor Gombashika is also the Vice Chancellor, the Deputy Vice Chancellor of the university. She was with us throughout, and also the local leadership, as well as health workers. And also the program indeed attracted many, as well as the national TV, newspaper, and Facebook aired the project, and also was fully funded by GRN, which we are now here to make this presentation. We also had challenges. Time was a major challenge, as this was an addition to the students' normal school calendar activities, but they really worked hard and they managed to do such a good event. But we also had low participation from men during community activities. You know, men make a good influence, and a lot of people that we tend to lose a lot are men who do not seek health resources or health information. So we reached out and we had discussions with the community, and they promised that they will be with us next time. We'll be conducting other activities. Next slide. So according to our objectives, we are able to enhance our students' assessment and intervention skills towards health literacy, and we were able to assess the barriers, and we were able to intervene in our communities and also implemented the project successfully, and we also improved our relationship in the rural community plus the health workers, which is very vital for you as a health worker to conduct an intervention. You really need good relationship, so it was really good. Sure. Next slide. So we used the money for internet coverage, as you have heard in the beginning, that we conducted sessions before we went to the community, and also the funds really assisted us with buying materials that we used during our interventions. For example, sphygmomanometers, glucometers, MOAC tapes, which assisted a lot during our assessment. But also the funds covered the transport from the campus to the area, and also lunch and the healthy snacks that we bought during our education activities, which really also helped because people had a chance to also know how to prepare other snacks that are healthy. Sure. So back to Abby. Thank you so much.
Yes, so with our review of outcomes, we had our students and faculty engage in the project learning strategies, and we wanted their buy-in and input. So we asked the students to tell us what they wanted to learn, what challenges they felt were faced by rural communities in Alabama. And we did the same on the Malawi side, because we wanted to make sure that not only were our community members really in tune and bought into this program, but also that our students were excited and passionate about it, and that their learning needs were being met as well. So our academic members were paired with different groups within our collective collaboration. And so we had faculty and students pair off and present information. Digital content was shared, much like the image from our first project. And in collaboration together, they implemented many of the learning objectives, looking at health literacy, community collaboration, community engagement, cultural humility, etc. And so in collaboration together, we learned from, with, and about our friends in Malawi and our community members in both of our respective rural communities. And the response from the community after each of our sessions and interactions was really important. I reached a number of people through these awareness sessions. We were able in Alabama to help identify those who had had episodes of hypertension, some who had just been recently diagnosed and discharged with a disease or illness, or chronic health condition from hospital visits that had follow-up questions. We were able to direct them to resources. And then again, to be able to provide them with healthy snacks and other interactive activities and literature, etc. So we were very pleased with our sessions, and we felt like that we did have a positive impact on the community. And even just being able to represent our university and to be able to smile and wave, having students wearing our CCN crimson red colors, and to be easily identified out in the community, trying to make a positive impact, I think is always a good idea in terms of relationship building. So some of our strengths, we felt like this was a productive relationship that we formed. We feel like that it was very noticeable, not only to the faculty and students, but also to the community partners and the community clients that engaged with us. We felt like the student schedules with their academic calendar was really a strength, because they were able to help participate fully within the project and to be able to really have ownership and accountability. So it was really a student-led initiative on our end of things, and I know the same is true for Malawi. And we felt like it was an active partnership from both sides. So we formed a really tight-knit group and team and worked well together, particularly over the past 2 years. That was what was really helpful about our relationship, is that we had time to develop relationships and to know each other more personally, and as well as professionally. And so that's always a helpful thing. And then again, we had active participation on the Zoom meetings and then in the community for the project activity implementation day. And despite having some internet issues and some challenges with, time zone differences and daylight savings time is always an issue in the spring semester when we do our meetings, we were able to overcome those and to be able to meet each other and to learn with each other. And I think it was just a beautiful collaboration. Also, having the availability and the support funds from GRNEN was absolutely crucial to being able to implement our project. We were able to buy a lot of reusable items as well as the food, and being able to present the brochures, have those printed in a really nice format. We were able to buy blood pressure cuffs and thermometers and reusable tents and chairs and things that will really just help us go back out into all communities that we serve in this rural Alabama setting. So we're very thankful for the ability to do that. And for both institutions, both the University of Alabama and through our partnership with Malawi, that we were able to support this project. So I'll talk about some challenges, and then we'll close out with Fabi helping us talk about lessons learned and our conclusions. So some challenges, of course, we did have intermittent connectivity issues and unreliable internet. So for some of us, it was difficult if our students were in a clinical day and they were having to join from a conference room or a break room. That was a challenge because sometimes they were a little bit distracted or they couldn't be on the video camera. The same thing for our friends in Malawi, because it was toward the end of their day. Some of them had already made their way home, so they were away from campus. So they were not able to join on video because it was difficult with the buffering on the internet for them to be on video and audio at the same time. So just access to broadband internet was a challenge in these remote and rural areas. And then, of course, this especially impacted our Malawi colleagues, but it also impacted our students as well, because we do have students from rural areas. The time zone differences limited our availability for meetings. And then, of course, with the time zone and daylight savings times changes, Malawi doesn't recognize the daylight savings time like we do here in the US, which at least in our part of the US we do. And so that was always something we had to be cognizant of making sure to change the times. And then just the lack of health literacy data to drive our project was a real challenge, because we wanted to make sure that we weren't making assumptions or false assumptions about our communities, but it was difficult to get county level data for us in our part of the world, and I know it was as well for Malawi. And then just those overall trends, some of that information, like I mentioned, was just very outdated. And so if people have an interest in health literacy research, I think that there's a huge opportunity for people to explore more on that. So I will now turn it back over to Fabi.
Thank you, Abby. So on the lessons learned, we felt the distance as you have heard. We collaborated from US to here in Southern Africa, Malawi. So we felt distance is not really an issue for us to collaborate as fellow nurses from all over the world. Whenever we can learn, wherever or from which country, we can do it. So virtually was possible, and we can share a lot and strengthen our nursing skills as well as the population that we serve. And we live in two other parts, but we share many of the same issues in relation to health. academic challenges, and barriers to improving our community health. As you have heard that we both face the issues of low health literacy, and that really affects the clientele that we have, the patients that we have. So we have the same issues, despite that we are from different places. And in that, we can come together and have ways on how we can improve these barriers. So moving forward, we feel that we need to have more of these outreach programs in order to connect with people in their communities, not just serving them in the hospitals when they come to us. We need to be able to go there, especially in the rural areas, whom they are not very much aware of where to get the information. So we have community health nurses everywhere. It's our chance to reach out to the people. You know, prevention is better than cure. So when we reach out to them, wherever they are able to appreciate the effort that we have taken. And in the end, they're able to follow whichever ways that we have discussed with them. In the end, improving our health, improving the patient turnover rate, and as well as improving our patients' conditions. Next slide. So in conclusion, from our project, we have seen that students and faculty from University of Malawi, Kamuzu University of Health Sciences, as well as University of Alabama, Capstone College of Nursing, we engaged to learn strategies to overcome similar challenges related to health literacy. So we also saw that rural communities face similar health challenges, hence implementation models can be developed and applied once modified. So this project, as you have seen, has really helped us to understand barriers to health literacy in rural communities, both in Malawi and Alabama, which I'm sure they also relate to wherever we are. So it's all opportunities for nursing students to learn from one another about ways in which health literacy and health disparities is addressed in our respective countries. So it's also one way to demonstrate different approaches to teaching and learning our nursing field. So health disparities are there, but people have access to health care, and their social determinants of health were also discussed and compared, and they were tackled. Thank you so much for being with us. So these were our references. Over to you, Abby. Thank you.
Yes, and we would love to take any questions or feedback, and we're going to invite Paige and Belinda to join us in helping answer your questions. And of course, if they have anything that they would like to add, we would love to have them do so.
I don't want to take up too much time for question and answer, but I do want to say thank you to Abby and Febby for providing beautiful leadership on this project, that our students just gained valuable information from about different communities. In our college, there is definitely a focus on tertiary care, but this project was able to focus students on primary care and primary prevention, and Malawi does that so well. And so our students were able to really learn from their primary prevention perspective. And I think that is one of the most valuable things that we took from this. Through all the challenges, Abby and Febby were completely flexible and were able to show that adaptability to our students also. And this truly can be done across a lot of different settings. And it just proves that you don't have to get on an airplane to travel to distant lands to learn from one another. We can certainly learn from one another by Zoom, despite the challenges. It was a wonderful learning opportunity. So thank you both for your leadership. And thank you to GRNEN for providing this tremendous opportunity.
Absolutely. It was a team effort for everyone involved, so we really appreciate it. I see that David has his hand raised. I'm not sure about the capability of unmuting or putting in the chat, but we see you, David.
Yes, David, I'm going to go ahead and open your mic to let you ask your question.
Yes,
Hi.
Thank you. Yes, that one was wonderful presentations, and it's a learning. I have a few questions. One was digital implementation, or it was a research. Then number two, or maybe said that there was a lot adequate funding from Grenade. So how much was this to be enough? And then lastly, how sustainable is the project? It was mentioned there that it could be, the way it was tailored, it was supposed to be sustainable. Does it mean that it is continuing or it has just stopped? Thank you. Corey.
Baby, would you like to go first?
Okay, yes, thank you, David, for the wonderful questions. So the first one, whether it was an implementation or research, it was an implementation, but then even if program implementation, if people would want to write anything about what they have done for other people to learn, you can also write a paper from that. So basically, it was just a project implementation. On the funds, we received about 5,000 US dollars to split among our two universities. So each got 2,500 US dollars. So if you convert like to our currency, it was enough to buy the resources that we needed for this project. So Abby or anyone can take the last question, which is about sustainability of the project. Thank you.
Absolutely. One of the great things about the funding was being able to buy supplies that can be reused. And so every semester, our students on the Alabama side of things are going back out into communities, Hell County, Bibb County, Greene County, neighboring counties around the West Alabama community where our university is located, and they're doing similar projects. And so it may not be this exact same project, but we're still building and continuing those relationships with the folks that we've worked with over the past few years with this project. So in terms of that, it is sustainable. So we were really strategic about how we use those funds so that we would be able to go back out into the communities. And I think the same could be said for Malawi as well. I know they're continuing to work in their communities. So thank you for that question, David.
If you would, I would like to also just share a point about the funding. As Febby and Abby have shared that the grants offer $5,000 to be split between the partnered universities. When we open up the grant in March, you will note there we have made a change to that this year. It is still a $5,000 allocation. We still recommend that that be split evenly between the universities. However, we are adding a clause in there that allows for the universities to change the allocations between each other should there be need to overcome certain disparities, either for geography or for exchange rates. So that is going to be more flexible pending agreement between the two partners this year. We do have another question. I believe, I apologize if I'm not pronouncing your name right, but I believe it's Keisha. I'm going to open your mic for you. Hello?
Thank you. Thank you very much for this opportunity. And also, I congratulate the many speakers. Indeed, health literacy now is becoming the area of interest globally. And if we wanted to reach the sustainable development goal, health literacy is a critical part. But my interest is that WHO has appreciated that this construct is a multi-dimension, not only just reading, writing, numeracies, but there are other issues which are critical. So, well, are you able to incorporate those multidimensional in your assessment? Thank you.
I can speak to that briefly. We actually did a study at UA on our Alabama campus last year with the first project, and we surveyed their mental health and their cultural attitudes and engagement. look to see if a project like this is actually having an impact on the students as they participate. So not just the community partnership. And we found statistically significant results that the engagement and the mental health of students who participated in this program were positively impacted. And so, and looking at the Sustainable Development Goals, there are a few that relate to health literacy. I believe it's 13 and 17 and perhaps 6, if I'm remembering correctly. Those 3 in particular look at health and wellness, health equity, and sustainable cities and communities. And so with those sustainable development goals that are through the World Health Organization and the United Nations, Sigma Theta Tau is also partnering with disseminating those SDGs. And so we did look at those as we developed our plan, and GRNEN actually has an education committee that's looking at those and how we can implement that into our education. And so I think that is an important part of the conversation, and certainly probably likely due to the COVID-19 pandemic, we're having more of those kinds of conversations. So thank you for that question.
Okay, we're right about the
I have
top.
another question, Corey. Corey, I have another question.
Okay.
Yeah, I could see that there was some refreshment. In Kenya, where I come from, when you give refreshment, everybody will be there. So I don't know how they were managing this because, yeah, and also, secondly, next time if you don't have a refreshment, then people will not bother. How are they managing, especially resource limited countries like Malawi?
Thank you so much for the question. So the whole village, we had an estimated number of participants. So we managed to have refreshments and snacks for every attendee. So with the relationship that we have with the community, whether you bring refreshments or not, they actually attend. They are the people that are well to work with. They consider the health messages that we bring them as treasure. I understand what you're saying because I'm a community health nurse. I've gone into different areas where if you don't really bring refreshments, you don't have many attendants. But with the Kuloya village, it's one of the outstanding villages when it comes to health information and health utilization. I would have loved if the chief was here. He would have also mentioned the same. They have village committees that encourage people to treasure the messages that we bring them and to act upon them for their health to improve. So whether you bring refreshments or not, there are people that are welcoming, and that makes our work easier. So yeah, thank you.
Belinda, did you have something you wanted to add to that?
Yes. Thank you so much for the presentations, and thank you so much for Sharani for the grant. What I want is just like maybe to summarize whatever has been already commented on. One thing is about sustainability. Sometimes you want to see the things, the changes immediately, but I can assure you the impact this project has had on the students is something that they need to remember. The experiences I'm talking about is the interaction. Somebody is so many miles away from your country, and you are able to interact, you are able to exchange information and compare the situation. I'm telling you, that's something that will live with them, and it's sustainable. Sometimes we expect to see tangible things, but things that change within yourself, the way you look at things. I think it's something that we have to appreciate. But apart from that, issues of collaboration. I strongly believe that our students, they have appreciated the importance of collaboration, even us, the lecturers. We have appreciated because sometimes we think that we need to meet, we need to meet physically and start the collaboration. But what we have done, I think, is something that we have to sustain, not only with this project, but even with projects that we're going to have. For example, in our country, Malawi, we have several district hospitals, several nursing colleges. We can also implement similar things. So what I'm saying is sustainability is there, but it's up to us. It's up to us to continue, exchanging this information, publicizing the information, sharing to our colleagues, so that moving forward, for sure, we need to change. And issues about members of the community relying on services like money and the like, or gifts and the like, yes, they're very, very common. But maybe we are the ones who also have to break that thinking. People will flock to us if we bring good things. So the interventions that we brought, the health and literacy, I think those are very, very important things. And I also like the idea where our colleagues in Alabama actually went to a store and then they were able to do all those interventions. Those are ways to go. Because when people read those things, people see you, I think they'll appreciate, and then they will soon start changing their behavior. Thank you so much. Over.
Thank you. Well, we are just about out of time, so I want to thank our presenters today. This was an incredible presentation. I know I can speak for everyone at GRNEN when I say that we really enjoyed coming through the learning experience with you through your grant last year. To see you take it to the next level in your second year collaborating together has really been exciting and interesting. And exactly what we are hopeful as we put forth grant opportunities like this. So thank you for sharing. Thank you for your collaboration and the work that you're doing in your communities. As always, if anyone has any additional questions, you can see Abby and Febby's information on the screen. We also welcome you to share any additional questions that you may have on our website in the open forum community. We are all there. We are all happy to collaborate amongst each other in that area of our website as well. So thank you, everyone. The recording should be posted within the next couple days should you want to revisit this or share this with other peers or colleagues. We hope to see you all at a future webinar soon. Take care, everyone. Bye now.
Thank you. Bye.
Thank you so much. Bye-bye. Bye.